be aware that this episode discusses sensitive topics that some listeners may find distressing. If you or someone you know has been affected by any of these issues, please refer to the help and resources listed in the show notes for details of organisations that can provide support. Welcome to Mindful Merseyside, the podcast series which aims to improve everyone's physical and mental health in the Liverpool City region and beyond. This episode is called Finding Broken Hearts, and that's because we're going to be talking about congenital heart disease. Now, about 1 in every 100 babies is born with a heart defect, which I didn't realise until we recorded this episode, was so high and so common. Now, these range in severity from relatively mild to life-threatening conditions. But if the condition can be diagnosed before the baby's born, then the prospects are better. And this is just one of the many reasons that pregnant women undergo an ultrasound screen at around 20 weeks. It can, though, as we discover in this episode, be difficult to see a heart defect. The images are often quite grainy, and sometimes doctors don't realise there's a problem until after the baby is born. In this episode, we are going to be speaking to the clinicians who diagnose and treat them, and from scientists at Liverpool John Moores University, investigating novel ways to detect faulty hearts. And you're going to be hearing about a study that aims to do exactly that. And also, we're going to be hearing from families affected by congenital heart disease as well. So let's get into it. I am joined by Ian Dykes, Andy Powell and Leslie Sloan. Now, you're all involved in a project here at LJMU focusing on heart defects. Can you just explain briefly what the project is and what part you're all playing in it? Ian, I'll start with you.
Hi, my name is Ian Dykes. I'm a senior lecturer in molecular biology here at Liverpool John Moores. I'm kind of leading the project, I suppose. So what we're trying to do is improve the diagnostic rates for congenital heart disease. So we're interested in trying to develop a blood test that could be given to expectant mothers that could determine whether their baby is healthy or not.
Hi, my name is Petra Adamova, and I'm the PhD student that worked on the Ep06 study.
And Andy, what's your part in the study?
So I'm a senior lecturer in biochemistry, and my expertise is something called assay development. So that's inventing ways of doing things. Mm-hmm. So I complement Ian with being able to analyse molecules as part of the sort of diagnostic attempt to read out things in the mother's blood.
Okay, and how about you, Leslie?
Yeah, I'm a post-undergraduate here at LJMU. I've done my dissertation with Ian over the summer, and I'm now going to be starting on my PhD, taking over from Petra, but not doing the same thing. It's kind of like a big relay race. So she's done such a large amount of work, and now I'm going to do the next large amount of work.
Yeah, we're going to be hearing from Petra a little bit later on in the episode. She's a former PhD student, isn't she? And we're also going to be hearing from Robin Lotto, who's a co-investigator on the clinical part of the study. And we're going to be hearing from families who've been affected by congenital heart disease as well. But I think it's a nice place to literally start with the very basics. And that is, what is congenital heart disease? And you might hear that referred to throughout this episode as CHD. So Ian, can you just give us an overview of that?
Yeah, this is a disease which affects the heart, which is present in newborn babies. So it's quite different to the heart disease which affects adults. Mm-hmm. Something which is present at birth, and it's caused by some kind of error during the embryonic development of the heart. And this is actually the most common birth defect. It affects almost 1 in every 100 newborn babies. And it can range in severity from relatively mild disease to quite serious and life-threatening diseases.
1 in 100 is quite common, isn't it, really? What kind of effects does that have on somebody's life, Leslie?
Well, the milder cases, some people may never notice. Mm-hmm. They may never know that they've got a congenital heart disease, but others, they'll have low oxygen and they'll have breathing difficulties, or they'll be blue at birth.
Okay.
And that can affect the brain and the other organs as well. So early diagnosis is really important.
So you're mentioning that when a baby's born. Ian, what can doctors do when a baby is born with CHD?
Well, surgery is now quite advanced, and actually doctors can repair most congenital defects now. So most people who are born with congenital heart disease now survive to adulthood. The doctors can repair the heart, but the prospects for the child are better if doctors have an early diagnosis and also a very clear diagnosis of what the problem is.
And does that affect life expectancy? Obviously, Ian, you've mentioned, the heart can be fixed, but does that provide a normal or typical life?
Well, again, it varies on how severe the heart defect is.
Mm-hmm.
In some cases, so many patients have what's known as a hole in the heart, and that can be repaired relatively easily. And I think they have a pretty normal life. Some patients have a much more severe disease where some of the blood vessels are connected to the wrong place and things like that. And doctors can provide palliative treatment for that, so they can improve the life expectancy and so on. But it's still a bit reduced compared to other people.
Right, okay. And this is something that I've only discovered recently as a parent, actually, because it became relevant to me because of my son. But all babies have holes in their heart, don't they, when they're in the womb? So how does that kind of manifest in a typical child or a child with CHD when they're born?
Well, it manifests by babies being born with a kind of a blue colour.
Yeah.
And that indicates a lack of oxygen in the face and the body.
Mm-hmm.
And that's because the blood carrying oxygen is mixing in the heart with blood coming from the body, which doesn't have oxygen.
Right.
And so the heart is less efficient. And therefore, the baby appears sort of out of breath all the time, and that kind of thing.
And am I right in thinking in milder cases, or, well, in usual cases, that a baby is born with holes in their heart and they close in the first couple of weeks of life? Or have I got that wrong?
Yeah, so the heart actually undergoes a lot of changes in the embryo. The heart actually begins as a single tube and later remodels to form 4 different chambers.
Mm-hmm.
So a lot of changes are happening both during embryonic development and shortly after birth as well. There are some holes in the heart which do close in a few days following birth, and that's because the blood circulation actually changes quite dramatically around the time of birth.
And before a baby's born, how is that currently diagnosed then?
At present, pregnant women go for a test at about 20 weeks of gestation,
Mm-hmm.
and that is an ultrasound scan. So that's obviously when parents first see an image of their unborn child,
Mm-hmm.
and doctors can use that same sort of image to look at whether the heart has formed normally and whether it's functioning properly. And they also look at other organs at that time as well.
And is that quite easy to spot in vitro, or can it be missed and not be obvious until the baby's born?
Yeah, so it's often missed. In around half of cases, it is missed because it's relatively difficult to see some of the structures in the heart on an
Right.
ultrasound.
And most surgery for CHD is performed on babies older than 6 months. Am I right in saying that?
Some are younger. There are some surgeries that aren't as major, but they're done to kind of improve oxygen going to the organs until they're older and strong enough to have a proper surgery to repair holes or vessels that have defects.
And if that surgery is performed later on after the 6 months, why is it so important that babies are diagnosed before they're born, Ian?
Well, it's very important because, as I mentioned earlier, the blood circulation changes very dramatically at birth. So that's a very important time for the heart.
Mm-hmm.
So there are some heart conditions which I think can be fatal at birth. And it's quite important that doctors know that at that point so that they can begin treatment immediately.
Right, so they can be prepared
Yeah.
to start straight away. That makes sense. So talk to us about this study then. Exactly what is the study that you're doing?
Well, what we want to do is to examine the blood of mothers who are pregnant,
Mm-hmm.
and to see if there's anything different in the blood when the mother is carrying a baby with congenital disease versus a normal pregnancy. So we're interested in analysing blood and looking for these very small particles which are present in the blood. And we believe some of them are produced by the growing fetus in the womb, and they enter the mother's blood,
Mm-hmm.
and we can then detect them in the mother's blood. So we're looking for any differences in those between women with a diseased pregnancy and healthy women.
And Andy, what's your part in that?
Well, so these particles, they carry molecules with them, and part of their natural role is to communicate. So we're interested in seeing if there is a difference in some of the molecules carried by the particles
Mm-hmm.
between a mother with a potentially diseased fetus and then the normal pregnant mothers. And the sort of molecules that we'll be looking for are RNA molecules,
Mm-hmm.
proteins, and then some complex carbohydrates And these can either be within the particles or they can decorate the surface of the particles. And the key question will be, do these molecules change to signify diagnosis of the potential congenital heart disease?
And Petra, how have you been getting mothers to take part in the study?
So as the name suggests, the Ep06 study was a human study that tried to chase extracellular vesicles. Mm-hmm. So extracellular vesicles are the small particles we focused on in this study. Mm-hmm. They are found in blood, and we study them to try and find a disease marker of congenital heart disease. So to do this, I had 3 participant groups. First, a non-pregnant control group, mm-hmm. which consisted of mainly students and staff from Liverpool John Moores University. Mm-hmm. This group was particularly important as when you were trying to find a marker of a disease present during pregnancy, you want to make sure the marker is not detectable outside of pregnancy.
Yeah.
So making the marker pregnancy specific was step 1. And this group allowed us to do that. Mm-hmm. Additionally, the particles we looked at are affected by various diseases and conditions, which is why I made sure this participant group was heavily controlled. And so I only recruited women with a healthy BMI and made sure to take blood on days 1 to 4 of their menstrual cycle, ensuring we control for hormonal spikes that we often see in women as well. Mm-hmm. But the next group were the healthy pregnant women. So these were women carrying a healthy pregnancy. And we worked with the research midwives at Liverpool Women's Hospital. And together we recruited 20 women for this group. So we identified women coming into the antenatal clinic and sent out the information about the study in advance to give the women at least 24 hours to think about taking part in the study. And, not to just ambush them once they come in, but to have them think whether they wanted to take part or not. And then at their appointment, I approached the women again. I walked them through the study. I explained the importance. And if they were happy to take part, I took a blood sample from them as well. Mm-hmm. The final group was the congenital heart disease group. Now, this group was very different to the other groups. We worked with the amazing team at the fetal maternal clinic at the Liverpool Women's Hospital, where women get referred to following their routine 20-week scan for a follow-up consultation and an ultrasound. And as mentioned earlier, it is sometimes difficult to see the heart at the 20-week scan, and so a referral to a specialist is preferred for kind of a final diagnosis. And these guys were really experts in their field. So how it worked was the woman came in, they're often anxious as they have an initial diagnosis they have been referred with in mind, and they had the scan, after which they got told whether there was in fact something wrong with the baby's heart or not. Mm-hmm. And as you can imagine, this often caused more distress to the mother, especially if the diagnosis was confirmed and she was in fact told her baby has, or her baby's heart has a problem. Mm-hmm. However, following the scan, the clinicians and I went into a consultation room with the mothers where the baby's heart condition was discussed in more detail and kind of questions about the condition were answered. And once the clinicians were done, I then was given time with the mothers to introduce them to the Ep06 study. Now, as you can imagine, this initial conversation was kept very brief, providing the mothers with the basic information about the study, and I just gave them a leaflet as I didn't want to cause, further distress to the mothers. Yeah. Especially when they had other things on their mind at the time. Mm-hmm. But the mothers then returned 6 to 8 weeks after their initial scan for a follow-up scan and a follow-up appointment. And having had time to think about the study and whether they wanted to take part, I spoke to the mothers at these appointments. And at this point, the conversation was a little more positive. I managed to actually recruit all of the mothers that came back for their follow-up appointments. So the success of the study was very high at this point. And the conversations I had with these mothers at these appointments were very inspiring as well. As the mothers, despite them obviously going through a rough time, they really saw the importance of the Ep06 study. And they wanted to know more, and they wanted to take part in the study to hopefully in the future help mothers that are going to be in the same position as themselves with, an earlier diagnosis for their unborn baby, because having a non-invasive test like a blood test to confirm a diagnosis is something that they really seek out and hope to have in the future. Mm-hmm. So this was just, I loved working there. But for all of the groups, I collected one blood sample, which I then analyzed at Liverpool John Moores University. And overall, I'm very pleased with how the study went. We were able to find markers that are pregnancy specific, as well as markers that are linked with congenital heart disease. However, to be able to turn these markers into a blood test in the future, I think more experiments are still needed to be done.
Yeah.
To have kind of that confidence of finding that marker or a disease signature, as we like to call it. But we hope to use the data from this study and hopefully have a larger study with more participants in the future to be able to confidently identify that marker of congenital heart disease and hopefully one day turn it into a blood test and help many families with an earlier diagnosis.
And Leslie, you're doing some studies in the lab, are you?
Yeah. So I'm growing cells and looking at the exchange of these particles between different cell lines. I'm hoping to grow placental cells so that we can see if they pick up any particular signals so that we can find the particles that are from the fetus and not just the mother.
So I feel like obviously we've got quite technical and quite medical. I think it would be really nice to find out exactly what life is like for families affected by CHD. And Robin's speaking to some of those families to get some insight.
My name is Vicky and I'm mum to Ava. Ava was born in 2012. We were diagnosed at my 20-week antenatal scan that she was going to be born with a cardiac condition. Unbeknownst to me, as a first-time mum, what we were to face ahead. I was told at my antenatal appointment that my daughter was going to be born a single ventricle child. I was unaware of any cardiac conditions because we do not have any cardiac issues in our family. So it was hard to digest, it was hard to swallow. And as being a sort of an older mum, because I was 33 when I had Ava, it's sort of like, I was like, have I done something wrong? Has something happened? Have I ate something? Have I drank something? All these thoughts go running through your head. But anyway, I asked all them questions and it was all, no. It's just one of them things. And it was explained to me, and I had a picture drawn by the cardiologist of a normal heart and a single ventricle heart. And I was told that Ava might not make it to 39 weeks of my pregnancy, that she could pass away in the womb, or she could be born with other conditions. But at that point, I knew I was having a little girl. I knew what her name was, and I had visions of what she looked like. So I couldn't think of anything worse than when they asked me to terminate. The answer was no, obviously, and 12 years later, we're still here to tell the tale. So when Ava had her first surgery when she was 3 days old at Alderhay Children's Hospital, that was probably one of the worst times of my life. That was a point of no return for me and my family. There was no going back on this now. I had to be her pillar of strength. But she was my pillar of strength. So she had a Norwood, which was a 16-hour operation. Then when she was 4.5 months old, she had a Glen, which was, it was okay. It was, she was up and down throughout that. Obviously, she was a little bit older, so her body was a little bit, more wiser to it. And then she had her Fontan when she was 4.5, and it was that we hit bad times. We were in hospital for 27 weeks in total, and Ava had numerous problems. The first 2 operations, she sailed through them. It was great. And I had all hope that this last one would be textbook and go the same. It never. But anyway, we got through it and we came home, and Ava now lives a happy single ventricle child life. She's restricted from doing keeping up with her peers, PE. running around. But she is a perfect child. She's beautiful inside and out. She has the biggest heart. She adores animals. And she is just the highlight of my life. And being brought into the cardiac world has made me a completely different person. I've grown to be less selfish. I've learned that we're not all the same. And I know that all children don't fall out of them little red books that we get given when they're born. So, as far as I'm concerned, I'm forever in debt to the NHS. I owe them my life. And that's why I'm part of a charity called Team 1C. I help support other parents that are coming into the cardiac world. And it's not a small world neither. It's a huge community. And we try our best to just help parents get through some really tough times and some really rubbish situations. But yeah, so that's me. That's Ava. We're single ventricle. I'm my mum. She's my daughter. And any questions, I'm here to help. Thank you.
Hi, I'm Claire and I'm mum to Jake, who's 8 years old. Jake was born with a heart condition and we didn't know about it before he was born. We were basically in the process of being discharged home after Jake was born, and a midwife decided he didn't quite look right. She listened to his heart and said it sounded a bit irregular, ordered an ECG, and the next thing we knew, the doctors were in the room telling us that we couldn't go home and he was very poorly and needed to go to special baby care. So he literally went from his car seat to special baby care. We had no idea before he was born. Jake's condition was arrhythmia, and at the time he had a heart rate of 300, I think it was, and also poor heart function, heart failure called cardiomyopathy. So, yeah, we didn't know before he was born. It came as a complete and utter shock and was obviously quite traumatising because we were literally ready to go and have a normal family life, and within the space of minutes that didn't happen. The team where Jake was born kept Jake stable with guidance from Alder Hey overnight, and then the following morning he was transferred to the cardiac ward at Alder Hey, and that's basically where we lived pretty much for the first month of Jake's life, I think it was. He was a complete enigma to everyone because no one could really understand what was causing the arrhythmia, and they weren't sure whether the rhythm was causing the poor function or the poor function was causing the strange rhythm. So there was a lot of head scratching and a lot of speaking to other hospitals in this country and overseas. And then eventually we were discharged home and Jake was on some heart rhythm medication. About a week later in outpatients, they decided that his heart function was much worse. And he was admitted to try a heart failure drug. And during that process, he got really, really sick. He arrested on the ward. He needed to be resuscitated and was taken to ICU. And from then on, basically, we pretty much lived in Alder Hey up until he was about 7 months old, I think it was. And then we were helicopter transferred to Great Ormond Street in London and put under the heart failure team and the inherited cardiac disease team. They decided that Jake's best chance at this point would be to have a bespoke pacemaker that would kind of help his function as well as pace his heart. And that was performed a week before his first birthday, which went really, really well. But unfortunately, there were complications and Jake had another cardiac arrest. They then decided after that he also had a hole in his heart, which they weren't too concerned about until he had this arrest. And then when they did an echo after this second arrest, they realised that they really needed to close the hole in the heart. So they did that the day after his first birthday. So he was asleep for his first birthday. And yeah, he was predicted to be very unstable after that. But fortunately, it was an absolute game changer and he was really well. He came off the ventilator, I think, a couple of days later. And about 2 weeks later, I think we went home. And he was pretty stable for a few years after that with his pacemaker. and a lot of cardiac medicines. But unfortunately, during lockdown, he got really, really sick and his heart function got worse. And he ended up being flown back to Great Ormond Street. And at that point, his heart was so poorly that there wasn't anything they could do other than support his heart mechanically and put him on the urgent transplant list. So he had a huge operation to have a Berlin heart fitted, and that took over his cardiac output whilst he was on the transplant list. And 2 months and 2 days of being on the transplant list, we got the call. Fortunately, the transplant went ahead and Jake made a really good textbook recovery from his transplant surgery. And he is now absolutely thriving and has loads of energy and is doing really, really well. I don't know if being diagnosed earlier would have changed the outcome. Would he have still needed a transplant? Probably. But, you know, if we'd have had time to prepare, because obviously it was just pretty much by chance, by this midwife's inkling, that it was picked up on and we didn't go home. If we'd have gone home with him, he probably wouldn't have made it through the night, I don't think, that first day. So, yeah, Jake's heart condition was picked up sooner. We could have been a bit more prepared. The centres that were looking after him and caring for him could have been more prepared. He could have got more appropriate treatment. It might have saved him some of the trauma of the things he's been through, because he's been through, like, you know, being resuscitated numerous times and all the IVs and maybe medicines that weren't appropriate for his type of rhythm condition. And it might have bought him some time with his old heart. So I think it's really important that people are screened when they're pregnant and these conditions are picked up on. Jake's is obviously a bit of a strange one because it's quite a rare thing that he had. But, you know, knowledge is power, and if you're armed with the facts before the baby's born and everything's in place, then they've got the absolute best possible chance of survival once they're born. So it's just really, really important. So as well as being Jake's mum, I am also the founder and chair of a charity called Team 1C, which is a charity that is run by completely volunteer cardiac families for cardiac families. We originally started off as fundraisers for other charities, and then we started doing things socially and became more of a support network for cardiac families. So we decided to register as a charity in October 2022. During that time, one of the things we've done is provide training for sonographers so that they can train to pick up in scans CHD. And we've also paid for equipment like a cardiac sim doll so that technicians can train on scanning babies' hearts but without actually disturbing a tiny poorly baby as well. Yeah, we just think, you know, let's give everyone the best possible chance of survival and hopefully save families some trauma. Wouldn't particularly wish the journey we've been on for anyone, but obviously very, very grateful that Jake's still here and really grateful to all the teams that have done their best to keep him safe. And that's one of the reasons why I founded Team 1C, basically to try and help families have the same chance that Jake's had. So yeah.
Thanks for that, Robin. And also thank you to the families that spoke to her. It was really insightful and a really interesting listen to find out exactly, really emotionally and just in a general life sense, how CHD is affecting families. So what is the long-term aim of the study? And Ian, let's start with you.
Well, our long-term aim is to improve life prospects for patients with congenital heart disease.
Yeah.
So we want to do that by improving the rate of diagnosis before babies are born. So the overall aim of the project is to try to develop a blood test that we could give to mothers maybe when they come in for their ultrasound scan. And that would provide more detailed and accurate information on whether they carry congenital heart disease.
And I'm guessing that should be fairly easy to implement, given that pregnant women have multiple lots of blood taken all the time. So it's just kind of adding on to things that are already being screened for, is it?
Yeah, it will be. So there's a lot of vials of blood that get taken.
Yeah.
I remember when I had my little boy, it was almost constant. So I'm sure you wouldn't mind one more vial being filled up.
No, absolutely not. And Andy, what are your thoughts on the long-term goals?
Well, the key thing would be we'll be looking for what we call signatures, molecular signatures, and we're hoping to find particular signatures within the blood that correlate with the disease. Then the next step would be how to effectively implement this into a hospital laboratory and make it a standardized test to diagnose parents potentially with a CHD baby.
Mm-hmm. Well, thank you so much. It's been a really interesting chat. I've really enjoyed talking to you. Thanks, guys.
Thanks very much.
You've been listening to Mindful Merseyside, brought to you by the Institute for Health Research at Liverpool John Moores University and produced by Inabella Media. We hope you found the conversation informative and insightful. If you or someone you know has been affected by any of the issues discussed in this episode, please refer to the help and resources listed in the show notes for details of organisations that can provide support. I've been your host, Gemma Cutting, and don't forget to subscribe to Mindful Merseyside wherever you get your podcasts. Thanks again for listening, and I hope you'll join us again soon.